Hello, everyone. Welcome back to the Ask the Educator podcast. My name is Adam Okada. Our host, Kevin Anderson, is not able to be with us today, but he will be missed. And today we're going to be talking to Dr. Ann Drosnock about her recent webinar that was done in September 2025 on kind of updates and things like that for flexible endoscope reprocessing. So, Ann, welcome to the podcast.
Thank you. Glad to be here. It's been a little while.
It has been a while since you've been on, so we're glad to have you back. But let's jump right into that webinar. If you're interested, it is on Healthmark Academy, talking about endoscopes and updates in the industry. But let's talk about this concept of high-risk endoscopes and additional testing recommendations that we see in ST91. Can you speak a little bit about that additional testing?
Sure. When we were developing ST91, we kind of landed on the language of having a category of endoscopes called high risk scopes. And those are scopes that have been more frequently implicated in outbreaks, cross contamination. They may just be more complicated by nature, harder to reprocess, and therefore have a higher risk associated with their reuse and reprocessing. So we thought it really a good idea to designate those as being high risk, which is the first time we've really seen that done in a standard or a guidance document like that. And that's to call attention to these different types of scopes and really to get people thinking that I need to either prioritize them or do something more with them. So we have a standard process for what to do for all types of endoscopes, right? But then there are some different designations on what you would do if it's a high risk scope versus not. So just one example that we have in ST91 is related to cleaning verification testing. So that is testing for residual debris after manual cleaning prior to disinfection or sterilization. Not doesn't matter what product you're talking about or anything like that. All cleaning verification products are meant to be used after manual cleaning before it goes into the AER or before it goes on to sterilization. And oftentimes we see people confuse that and do it after the fact, after it comes out of the AER or after, it's in storage. That's not appropriate for any of them. They're meant to check for debris after cleaning to show that it can go on to the next step in the process. So that's a key factor I want you to keep in mind because some people think I'm not really sure what I'm talking about here, but it's a test for something like protein or ATP or combination thereof of different markers. So the different differentiation between high risk scopes and non-high risk scope is really important when it comes to cleaning verification because in ST91 we have it as a requirement, which means it's a shall statement, and that every high risk endoscope shall be tested for cleaning verification after manual cleaning. So, again, requirement every scope, every time, doing something for cleaning verification on those types of endoscopes. And that's you just want to ensure that they're in a state that can go on safely, hopefully safely, to disinfection or sterilization. Because remember, we talked about things like not doing a good job in inspecting these scopes, and then if it's not inspected and it's used in a state of disrepair, then it doesn't matter what you do to that scope, it's not going to be safe for a patient. Whereas with the non-high risk scopes, we kept it at a recommendation to do cleaning verification on those, but the interval has to be decided upon by the facility. So if you have a non-high risk scope, as an example, it might be a colonoscope is a typical one. It's really up to your facility to designate what, in addition to those listed as always high risk, if you have others other than that you want to call high risk, you can do that. But for those non-high risk endoscopes, we asked for a statistically significant portion of those cycles to be tested. So it's about knowing in the facility level how many scopes are going through the process and doing some calculations. And we have examples of that in ST91 to help you figure out what that is. And I'll be honest with you, some facilities are like, I'm not going to do that. I'm just doing every scope every time, or I'm doing every high risk every time. And then daily I'm testing every other endoscope, every non-high risk scope. So there are some varying ways that you can implement it, but the concept of high risk scopes are really new in ST 91 for a standards application, and those are your complex types of devices like duodenoscopes, ultrasound scopes, particularly linear EUS scopes, ultrasound scopes, bronchoscopes, don't forget about those, and ureteroscopes and cystoscopes are the main ones.
Awesome. Yeah. And it's really an important recommendation because those are the ones that were having a lot of infections associated with them. So that's what we classify as high risk. And then other scopes you can classify at the facility level if you're having outbreaks with other types of scopes. Those can
Right.
certainly add to that list as well.
So you might have a certain patient population in your facility, like organ transplantation, where you're going in to check something in particular. Well, if you have a patient that's that ill to begin with, then you might want to designate those scopes as high risk and do more with them.
Yeah, absolutely. I mean, it's all really good recommendations, and a lot of this is already in ST91. A lot of this explanation, but I know there are still hospitals that aren't aware of these changes and things like that to those high risk scopes.
Mhm.
Another change to the recent 2021 version of ST91 is the recommendation of a 60 seconds for our leak testers. That changing from I think it was 30 seconds previously, and then are there other issues with the leak testers or other things we should be looking at with our leak testers?
Yeah, that's a great question. And just to go back to the amount of time required, I think it's important that I, people always like to hear the background of how we got there. And it was funny when we were originally going through these new changes, we thought, okay, well, 30 seconds should be good enough. And it was actually the end users that were on the group that were like, whoa, whoa. If you want to do a good, thorough leak test, for you to submerge that scope, get everything connected, and then you're doing all the observations that the IFU tells you to do, where you're angulating the knobs and pushing the buttons and all that, it takes longer than 60 seconds plus a time to observe that. So it really came from the end users telling us that 30 seconds isn't enough time to do a good, thorough leak test, that we upped that and then changed it then to 60 seconds. So, I think that, people, sometimes people erroneously think that we change things just to make it harder or make the process longer. But a lot of times it's the feedback from the actual technicians in the facility that are telling us that is not, we're not able to do that. So we need to make it more stringent. So this is one of those cases where that came from. But there are other things to look at. So again, your IFU may say 30 seconds. So you're following your IFU, but if your facility says it's following AMI standards, you need to up that to 60 seconds to be compliant with that. Beyond that, also, we now have recommendations in there to check your leak tester itself. So think about this as confirming that the leak test unit you're using is actually outputting the correct pressure. Because if it's not, you're going to have false results that your leak test is passing when actually that scope could be damaged. So it's a safety risk to our patients because a lot of these will emit air and you'll hear the psst when you press the lever, the button like it says to do in the IFU, but your psht might be different and my psht might sound different and you really don't know, right? So it's a very subjective test to know whether that's working or not. And that's why we put a recommendation to test the pressure of your leak tester every day that it's used and document that pressure amount to make sure that it's actually at above the minimum that it should be so that you're getting accurate leak test result. That's the main one that we've added, the doing that part of testing the leak tester and documenting it.
Yeah, that was always my favorite thing about going in after that standard came out and going to customers and having them just put their finger over the button. Oh, that it works because I can hear the psst sound. But
Yeah,
then you test the PSI and they were, oh man, it's like super low. And how
really
long has it
low.
been low?
Yeah.
And yeah, it's always kind of shocking. But that is an important thing to call out in the new standard.
Yeah.
But what are some of the most recent changes in flexible endoscope processing? So I know that in the webinar you talked about some FDA recalls, the duodenoscope delayed reprocessing change or challenges with those. Can you talk about some of those changes you discussed in the webinar?
Yeah, I think that we haven't had a new standard come out in a while, so it's not really guidance that's different at this point. But what we're seeing with the action that the FDA has taken is really showing us, or bringing to the forefront again, how they've not forgotten that these duodenoscope and just general endo processing issues still do occur. So I think the two that I want to highlight really are the duodenoscope change. So when they recently, Olympus came out with a new IFU for the TJF duodenoscopes that removes any mention of a delayed reprocessing time frame. So we used to have 1 hour between pre-cleaning in the procedure room and manual cleaning in the processing area. And the new IFU removes that, because what they found is in ongoing studies, we call them post-market safety surveillance studies. So what's actually happening in the field with endoscopes that are in use at hospitals is if those scopes sat longer than an hour, that they had a higher contamination risk with them. That's serious to me, because we already know we have an issue with duodenoscopes, and the original post-market safety surveillance cultures that were mandated by the FDA showed that there was somewhere on average of a 5% contamination rate with high concern organisms on these scopes to begin with. And then if you add in a longer delay, it's even worse. So they've eliminated that allowance for time in there. But that's a challenge, Adam, because how are you going to make sure you prioritize now? What you're prioritizing these scopes through the process over everything else? Then what your other scopes sit? It's a really bad position, I think, for facilities to be in, to try to figure out what to do with this. And then we're not really getting good guidance on what to do if you do have a delay in reprocessing, because inevitably that's going to happen in places that something gets missed and that duodenoscope sat there for longer than an hour. And this is my opinion, and I've heard that some facilities are, if it does go beyond, like there is any kind of delay with those duodenoscopes, then they're looking for some way to sterilize them, just as that added risk mitigation step in there. But duodenoscopes again are challenging, because you can't just throw them in a steam sterilizer. You can't really easily low temperature sterilize them in vaporized hydrogen peroxide. There are some exceptions to that nowadays. So ethylene oxide, and who's got that left to use? So it's a challenge. Then what do you do? And some facilities want to send it in for like a new channel, and it's getting very complicated. And I'm hoping there'll be more guidance from scope manufacturers in the near future on what to do with those instances when we do encounter a delay with duodenoscopes in processing. So not great news. The other thing briefly to talk about is the import hold on what's certain Olympus scopes being shipped from the Japanese manufacturing site into the US, and that those can no longer be imported, and the same with the AER. So that's going to be an inventory challenge potentially for facilities who want to purchase those new types of scopes. It did not extend to GI scopes at this time. I can't make any guess as to whether that's it, whether it's going to continue. Maybe those types of scopes aren't made at that plant. I don't know. But for now, it is a challenge to think about what happens if you need to order more of those types of scopes, like the bronchoscopes, for example. But you can continue to use the scopes you have if they're inspected and in working order. So goes back to what I was talking about on the webinar, and making sure that we're doing a good quality inspection every time.
Yeah, it's so important and such a vital step, and such great information that you gave during that webinar. Things like that, hey, we have to be looking at the challenges that we're going to have with shipping and those kinds of things as well. So one thing that I think was really interesting that you brought up was the fact that flexible endoscopes continue to see the highest rate of infections from any other medical device. And then you also talked about some of the causes of them and injuries and outcomes. So can you speak a little bit? I don't want you to go, and recap everything that you
Yeah.
said during the webinar, but just talk a little bit about some of the issues that you've seen with scopes and the outcomes from them.
Yeah. And shameless plug to go back and watch that webinar because I went through all of those slides and you can really look at them in more detail if you want. And I have tons of references in there for pulling all of that data together for that. But I think what's really critical is, I wanted to show people that these issues are still occurring. And this was all recent data that we looked at, that if a scope is used on a patient and it wasn't inspected and it was used damaged on a patient, the risk of injury, here's examples of what can happen. These are all reports that went into the FDA. And then also, it leads to, if that scope has damage, it leads to a higher infection rate because the damaged endoscope harbors debris and bacteria and everything else. So really kind of trying to close the loop to show you that it's not just one-off cases. There are direct implications to not doing these steps that are already mandated or recommended in the standards that people just want to do, don't not people, facilities don't want to do because it's more time, it's added cost. Time is cost. I get it. I get all of that. But we owe it to our patients to do the best we can. And therefore, we need to do inspection after manual cleaning. You really should be looking at that scope at all. Every time you're touching it, right? You should be looking at it. But a distinct timeout to do a good quality inspection of that endoscope after manual cleaning when you're doing your cleaning verification is really key to preventing injuries and infections in our patients. We owe it to our patients to show, okay, this is damaged. And I mean, there were citations in there of scopes literally falling apart when they were used. Pieces of the distal end, the bending rubber, all of that breaking off and staying in the patients. And honestly, some people will laugh and be like, oh, it's going in the GI tract anyway. It doesn't really matter, right? Well, we have to expand our view of where these scopes are used. Coming from a background of endo processing, we always said, if you have a hole, we have a scope to go in it. And if you don't have a hole, we can cut a hole for that scope to go in it. So you have to think beyond GI. These scopes are used in lungs, they're used in kidneys, they're used everywhere. And a piece of a scope falling apart in a lung is a lot more serious than it falling off in the GI tract. But we see brushes that are popping out of endoscopes into patients, brush heads or bristles. We see stents. I remember back in the day, I had a report of a popcorn kernel popping out of a scope into a patient. Clearly, that didn't come from the patient. And then we have to do these really tough investigations to try to figure out what are the implications. How long has that been in the scope? Oh, well, I didn't use that stent for the last 4 times this scope has been used. So that's been in there the whole time. So, what I really thought and wanted to do different with this presentation is to bring it full circle to show the causation and the reality of what can happen if you don't do those requirements in the standard and what are considered best practices. So, honing in on doing a good inspection and stressing doing that inspection again in the procedure room. That's in the IFUs too, but a different IFU, Adam. That's in your pre procedure checks, which is in the instruction manual for the scope. So often those of us in the reprocessing areas don't ever even see that manual. It's often a totally separate manual than the reprocessing manual. So in there, they'll tell you to check the water feeding function and check the image on the screen and do all of these things. And one of those is inspect your endoscope to make sure that it's not damaged. So if you're not doing, things can happen during disinfection, things can happen during storage, things can outright happen during sterilization because it's a harsh process. So if we're not re-inspecting that scope in the procedure room before it's used on a patient, the chance for damage to that patient, damage of their ureter, as we said in the one example where the whole patient's ureter was torn out from between the kidney and the bladder, that's devastating. Or having to turn to open surgery to try to get a stuck scope out of the patient's kidney. These things are devastating injuries, and a simple inspection could preclude that from happening. And that's why I get so passionate about it.
Yeah, no, I mean, I think you're absolutely right. I mean, there's preventable things that we can be
Mm-hmm.
looking at. I mean, that we have the tools, we have boroscopes, we have cleaning verification tests. There's no reason why these things should continue to happen, but they do because I know we're all stressed with time and pressures and all those kinds of things. Do you have any final thoughts for the listeners before we end the episode here?
I'll say it's again my shameless plug to get involved. If this is something you're passionate about, endoscope processing or sterile processing in general, and you want to make the world a better place, right? Get involved. It's easy to do. Get involved with Amy, become members on certain committees, whether it's working group 84 for endoscopes, which writes ST91, or also writes TIR 99 for probes and dilators, or sterile processing ST79 for working group 40. This is your chance to give back and make things better for patients. And we're always looking at making sure we have more end users, whether it be the managers in the departments or technicians or even infection preventionists. We have a good group of IPs on those working groups, and it really takes a village to make sure that we're staying balanced and that we have a good approach to what our recommendations are. So making sure that as you who are responsible for processing endo or sterile processing or your IP, we owe it to our patients to do the best that we can do. And I can't say that they're always simple, but instituting these best practices and following standards that give us certain requirements or recommendations, they're there for a reason. And that's why I wanted to do the webinar today, and this follow-up pod, or this webinar for September, I should say, and the podcast today, to make sure that people are really thinking about the full circle of what happens if you don't follow them. And here's some published literature that says what the outcomes can be. So hopefully it went over well. And I'm always here as a resource if people need it, and I'm happy to follow up on that.
Absolutely. Get involved. Reach out to us, hmedu at hmark.com. That's our education inbox. But thank you guys for listening. Thank you, Dr. Mad, Dr. Mary Ann Drosnock, for being on the podcast. And we'll see everyone in the next episode.
Thank you. Thanks, everyone.